Okay, I think that's probably everybody that's probably going to log on. So,
Okay, so we have a smaller group today. It's summertime. Get it. So maybe, let's go around and do some introductions since we're a bit of a smaller group. Again, my name is Eric Arzubi. I'm a child psychiatrist and run Frontier Psychiatry out of Montana. Maybe we can start off with our Echo folks. I know, Amber, do you want to start and then pass it on?
Amber Rogers, I'm a nurse working at Mount Pacific and help coordinate these events. Mary?
Hi, Mary Argonis, Mountain Pacific at the Hawaii office, and I'm your IT support.
Thanks, Mary. Asta, how about you? I know Asta.
Hello, my name is Asta Rendell. I'm a psychiatric nurse practitioner, and I work with Dr. Arzubi at Frontier Psychiatry, and I primarily work with kids and adolescents.
Thanks, Asta.
Thank you.
Azriel. Oh, you're on mute.
Classic. You think you figured it out by now. I'm a pediatrician on the Big Island. I actually work with Jennifer, who's also on the call.
Cool. Let's hop over to Jennifer. Jennifer.
Hi, I'm trying to get my video working, but anyway, yeah, I'm a nurse practitioner, pediatrics, Big Island. Been here for a long time. Interested in this subject, see the need so much right now. So glad to meet you.
Thank you. Appreciate it, Jennifer. Kristen.
Hi everyone, Kristen Capel here. I'm an RN manager with one of the health plans and I'm here on the Big Island.
Thanks, Kristen. Lindsay.
I hope my audio is working. Can you guys hear me?
Yeah.
Cool. I am an occupational therapist in Montana, and I work at a rural hospital doing inpatient, and I am trying to branch into doing telehealth for mental health.
Awesome. Thank you. And are you thinking about doing telehealth for mental health for OT or nice? That's great.
Thank you.
Michael.
So I am a social work licensed candidate in Polson, Montana, and I work for St. Luke Community Healthcare.
Thanks, Michael. A lot of need in the St. Luke area. How about Assad? Is it Giasudin or Giasudin? Sorry.
Hi. Yeah, I'm a pediatrician and adult psychiatrist and child psychiatrist in Honolulu.
Great. Thanks for joining. And it looks like we have one more person who joined, Asha. Let's see. Asha, welcome. We're just doing some introductions, and it happens to be your turn if you want to introduce yourself. Tell us what you do and where you are. Asha. All right, you owe us.
Sorry, good morning. No, I'm sorry, double muted. I apologize. I am
It's okay.
Asha. I'm a licensed clinical social worker.
Wonderful. Thanks for joining, Asha. Cool. So yeah, so today we'll be talking about substance use disorders in adolescents, and then it looks like we might have someone with a clinical case to talk about. So that's great. And in general, for those of you who have been on some of these calls before, I like to think about big picture first and always, just to give us some context about what the heck's going on big picture wise, and then zooming in. That way we don't kind of lose the forest for the trees. So let me go ahead and share my screen. And here we go. All right. So, and because I was really last minute in submitting the slides, this is why they don't look as pretty as usual. So it's my fault, nobody else's fault. There you go. Cool. Overview of substance use disorders. So just some data. This is from the National Institute on Drug Abuse and the most recent Monitoring the Future survey. Actually, this is kind of interesting if you look at the trend line. So this is basically, as you can see, they surveyed 12th, 10th, and 8th graders and ask about any illicit drug use in the last year. And the illicit drug use they referred to is use of marijuana, LSD, crack, cocaine, heroin, or other hallucinogens. And then any other narcotics other than heroin, like other than heroin, amphetamine, sedatives, or tranquilizers that are not under doctor's orders. So it's interesting. I'd be curious to see what kind of the analysis is from people who are smarter than I am, but kind of interesting if you look at the drop here in this last in the last year, right? So they asked in 2021 what happened the last 6 months, and I got to believe this is very much related to the pandemic. Probably people staying at home more than before probably had an impact on this drop. But it'll be interesting to see what happens next year and these trends. And these are the data points that reflect that change, right? So if you look at kind of 8th grade, 14.7%. And it starts, seeing a little bit of a downtrend. 2019, a pop, and then here a drop down to 10.2%. Big drop here amongst 10th graders, goes from 30.4% to 18.7%, and then seniors in high school going from 36.8% to 32%. This is the lowest number in the 11 years that are listed here. So again, you've seen this, and I'm going to keep showing this every time we meet, probably, because I just want everybody to remember context. Keep in mind, right? So down here is age in years, and here is the cumulative percent of children who can be diagnosed. This is a 2010 big 2010 epidemiological study. So again, right, the first disorder to emerge in kids tends to be anxiety disorder, then behavioral disorder, and again, behavioral disorders, ADHD, ODD, conduct disorder. Then the green line is mood disorder, right? So that's unipolar and bipolar depression, but most of this obviously is unipolar depression. And then here, the purple, the bottom, you're seeing substance use disorders, right? You tend to see a little bit of a signal here at age 10, 11, then it starts to really accelerate up, right? So again, anxiety disorders, behavioral disorders, then in green you have the mood disorders and substance use disorders. And that way you always have in mind kind of what the big picture epidemiology looks like. And again, this right here, just statistics that support that data. You guys have seen this before and in other charts. So other presentations, you'll see if you kind of look at all the way at the far right here, right? These are the percentage of kids who are diagnosed, who can be diagnosed with any mood disorder before age 18, right? So there's lifetime prevalence up to age 18. So 14.3% of kids can be diagnosed with a mood disorder before age 18. 32% can be diagnosed with an anxiety disorder. Next page, 19.6% of behavioral disorder. Any substance use disorder, 11.4%. So again, what does this mean? Before the age of 18, 11.4% of kids can be diagnosed with a substance use disorder or will meet criteria for a substance use disorder at some point in their lifetime. And then any class, this basically tells you that before age 18, about half of all people before age 18 can be diagnosed with a psychiatric disorder. And again, just for emphasis and just reminding us, context is always key, right? Remember, kids don't live in isolation for the most part, it's always thinking about the systems that they participate in, right? There's a family system, the school system, and others. So always thinking about family dynamics, presence of psych disorders in a parent or guardian, and in this case, obviously substance use disorders, contribution of adverse childhood experiences, and again, as a reminder, and we'll see this again, there are five forms of family dysfunction, 3 forms of abuse, and 2 forms of neglect. Those are your 10 ACEs. School system, what's going on with school performance? Number one, what is the impact of a disorder on school performance, and vice versa? Can a child with a learning disability who struggles with school performance start developing a psychiatric disorder as a result? And then is there bullying involved? And then here on the far right, what's going on with food or housing security? And then are substances involved? Okay, like most things, that's a combination of environment and genes. Genetic factors account for 40 to 60% of a person's vulnerability to addiction. And then environmental factors are the other, right? And the environmental factors are some of the things we described above: family system, school system, adverse childhood experiences, that sort of thing. And then the comorbidity of mental illness. And as you can imagine, if there is a comorbid psychiatric disorder, the risk for developing substance use disorders goes up. And so if we're thinking about risk factors, what are some early ones? Again, genetic vulnerability, prenatal exposures, problems related to attachment and neglect, right? ACEs, right? The bias, everybody is born with a little bit of a different temperament. So was this child born with a sensation-seeking temperament? Again, exposure to trauma, impulse control deficits, and learning disorders. And you'll see how impulse control deficits play into the development of substance use disorders here in just a little bit. And again, learning disabilities. And the learning disabilities piece, again, you see this kind of keeps coming back. Why does that have to do with anything? Well, again, children, we want to try to introduce feelings of success and competency to children as much as possible. So if a child is struggling in school because of a learning disability, doesn't feel competency, doesn't feel success, obviously that has an impact on mental health and self-esteem. Later risk factors: poor parental supervision and poor parenting skills, substance problems and conflict in family, heavy use in local community. So again, is that kind of a cultural thing? Members of the community, people they look up to. School failure, social skills deficits, using peer group. So again, a peer group that uses a lot, could be a gang, if they're involved with a gang. Poor affect identification, regulation. And again, this is, remember when we sort of self-regulation is a big piece of sort of psychiatric disorders. And remember, we've talked about that everybody feels sort of negative emotions and has feelings of distress. How we regulate those feelings has a lot to do with our developing a psychiatric disorder later. So, right, if somebody has a healthy, let's say, toolbox that and a set of tools that they can use to kind of self-regulate, that's a positive thing. If that's never been modeled or taught, or is, or there's some sort of biological genetic deficits, the self-regulation piece is a problem. And so when somebody feels distress, they might resort to maladaptive approaches to regulating emotions. Conduct problems, and then mental health problems. So I always find it useful to kind of review diagnostic criteria. There are 11 criteria, okay? And so in order to meet criteria, or to be able to be diagnosed with a substance use disorder, you need two or more criteria to be met in order to be diagnosed with a substance use disorder. So, and there are three categories. There are three categories of criteria. There's physical addiction, there's the drive, and then there's problems. So again, it's important to kind of keep these categories in mind. Again, you have the physical addiction. So tolerance, more substance is needed for the same effect, or keep taking the same effect, keep taking the same amount of a drug results in a decreased effect. So patient is developing tolerance. Withdrawal symptoms. So this is what happens when there are physical symptoms that emerge when use stops, and then it really motivates the person to kind of seek more of the substance in order to avoid these feelings. So that's physical symptoms. Next, the drive. Using more for longer than expected, wanting to cut down but can't. lots of time and energy spent using or getting the substance or recovering from use, and strong cravings and urges to use. So again, this kind of represents the drive part, the sort of drive dimension of the diagnostic criteria. So again, physiological is the first one, drive is the second one, and then the third is going to be kind of the impact on functioning, causing problems. So number one is knowing that using the substance causes problems but continue anyway, struggling to function at home or at work, continuing use despite related interpersonal problems, engaging in fewer occupational, social, or recreational activities, and using in physically hazardous situations, right? So, the fifth one, for example, would be drinking and driving, knowing it's a problem but continuing to do it anyway, not being able to stop doing that. So again, 3 categories: physiological, there's the drive, and then the problems that are being caused or functional impairment. And then under the first one, you have 2 criteria. The second one, you have 4 criteria, and then you have 5 criteria here. So in terms of how addiction kind of works, I think this is kind of, I think it's good, also good to review is big picture. Big picture, if you look at 1, 2, and 3, number 1 is kind of the binge intoxication stage, right? So kind of maybe at first, kind of the impulsive desire to reach out, get drunk or use and see what happens. And that continues to happen a couple of times. And at some point goes to the next stage where now you feel like crap if you're not using. So in order to avoid that feeling, you use. And then the third stage is kind of as it becomes more chronic, you have kind of this ongoing craving, right? And so if you look at the details of each one of these stages or these 3 dimensions, you have sort of the binge intoxication stage. That's basically it's dopamine release, right? And dopamine is a neurotransmitter that's released when the brain thinks happy things are going on, right? So when we eat, have sex, dopamine gets released. Same thing happens with alcohol and drug use. It's a dopamine driven. And the biggest burst of dopamine actually happens with the use of stimulants, in particular meth. Meth is just this massive dopamine dump. And the dopamine release happens in these 2 parts of the brain. One is nucleus accumbens, the other one's basal ganglia. Don't worry about it, just know that you got this dopamine-driven stage. Then next stage is the withdrawal negative affect stage, where now it's negative reinforcement, which means the person is using to avoid bad feelings. So you're transitioning here from impulsive use to now compulsive use, and you're starting to see changes in the brain. And so the brain's reward, executive functioning system, and stress systems are starting to kind of slowly get rewired. And then if you keep going, you have the preoccupation anticipation stage, which is kind of this chronic craving. You have a decreased sensitivity to natural reinforcers like food and sex, a decreased executive functioning, which means your ability to kind of control, impulses that are generated by these cravings are more difficult to control. And then you get these associated stimuli that are powerful triggers, like, let's say, driving by the liquor store and always having that compulsion or that impulse to want to buy alcohol. And this, again, you can kind of look at this when you get the slides, but this just kind of tells you which stage and what kind of parts of the brain are involved. But again, if you look at the very top, you have the binge intoxication stage. You go around clockwise, then it becomes a negative affect withdrawal stage, and then keep going clockwise, and you get the preoccupation anticipation stage. And then it tells you kind of what parts of the brain are involved. Again, being a child psychiatrist and knowing the impact that adverse child experiences have on both physical and mental health, right? Here just a graphic that this is from the CDC website. It basically tells you what are the risk factors. So adverse childhood experiences are risk factors or increase the risk that people will develop these things, right? So starting from the left, you got traumatic brain injuries, fractures, and burns, obviously. Then you have mental health problems. Then you have maternal health problems. You have infectious disease, chronic disease, risky behaviors, alcohol and drug abuse, unsafe sex, and then an impairment in opportunities in the future relate to occupation, education, and income. Again, a reminder, what are the ACEs? 3 forms of abuse, 2 forms of neglect, 5 forms of family dysfunction, right? Abuse, you have physical, emotional, and sexual abuse. Neglect, you have physical and emotional neglect. Household dysfunction, you have somebody in the household with mental illness, or in the household mom is treated violently, or there's a separation, a parental separation. Somebody in the household is using substances, or there's a relative who's incarcerated. Okay, so again, a little bit more about big picture prevalence in the United States and the general population. 20 million adults have had a substance use disorder in the last year, which represents 6% of the population. This is on 2014 data. 16.3 million have an alcohol use disorder, 6.2 million have illicit drug use disorder, and a small minority of folks with substance use disorders that you can see get the appropriate treatment. I'm going to go through I won't dwell too long on any one, but again, going through different substances, right? So you have opioid use disorders. 25% of patients who are prescribed opioids for chronic pain will misuse them. 10% will develop an opioid use disorder. And then 5% who misuse prescription opioids will transition to heroin. And flip that around, 80% of heroin users at some point misused prescription opioids. Right here you have some information about the opioids or pain relief, the pain relievers. And here this is just a kind of a very graphic indication of look how little fentanyl is needed to kill you. Look at the penny and then look at the little bit of powder. I mean, that's a fatal dose of fentanyl right there. So it's 50 times more potent than heroin and 100 times more potent than morphine. Here's just some data on Montana and looking at overdose deaths in Montana versus the United States. And this is basically looking at a ratio of the number of deaths per 100,000 population. And you see, in the United States, it's been spiking since the mid 2010s. Well, we know, even though we saw kind of a drop in use among teens that were kind of locked up during the pandemic, we know that alcohol use and other drug use kind of surged during the pandemic. Here, this is actually from the similar kind of survey. This is sort of similar data that I showed you before. What's a little bit different is it shows you kind of here the alcohol consumption. Breaks it down by teenagers. So 11% of the alcohol was used by teenagers. 89% of the alcohol was used by adults. This is so kratom. Quick, a little bit of information on kratom. This is sort of this is a botanical product that actually produces opioid effects at high doses. Sadly, it's legal in lots of places across the country. Cannabis, so cannabis is getting stronger and stronger, and we know, every year that goes by, we have more research that shows that chronic use of this, ever strengthening cannabis, meaning having higher and higher potency of THC, is increasing risk for psychiatric disorders, in particular psychotic disorders. And it's I've seen several cases where a youth has been using marijuana pretty much daily for a couple of years and then presents with a psychotic disorder that actually doesn't go away after cannabis is stopped. And so here you see some information. For example, THC is a CB1 agonist. And CBD are indirect CB1 and CB2 antagonists. Here you see kind of a trend in the concentration of THC in cannabis from 1995 all the way to 2014, and you see it almost tripled. And there's actually a study that was done in Europe where they took a look at the amount of THC in cannabis in different parts of Europe, and it actually correlated with psychotic disorders. So cities that had high potency cannabis were more likely to see people with more psychotic disorders being diagnosed. And obviously pertinent for how is it pertinent to our patients? Certainly in Montana now, it's being legalized, and there's a spillover effect where, you know, what's crazy about this is you're having legislators and people voting to tell us whether or not we're permitted to give out this substance, right? In other, you know, most other cases, it's kind of the FDA and people do it based on science, right? Here, it's kind of by vote. We're saying, yeah, let's make this legal, and that's a problem because it changes the perception people have of something like cannabis, because they figure, well, if it's legal, it can't be that bad, and that's just kind of a general feeling that spills over and makes it more likely that people will try it because they don't feel it's as bad as it was maybe when it was legal. Meth, obviously a real problem. Different ways that meth is ingested. Like I said to you before, meth is kind of the drug that produces the biggest dopamine dump in your brain, which means it's unbelievably addictive relative to other drugs. Here's a big list of problems that meth creates long term. What I would tell you is that we've seen, basically you have to use meth 2 weeks every day to start creating permanent changes in one's brain. That's all it takes. And then over time, the more and more someone uses, you know, the meth has these very toxic effects on the nerve cells when it dumps the dopamine. And that's why it being so toxic, it only takes 2 weeks of use to create permanent changes. And some of these changes will include actually sort of chronic psychotic disorders. And like other stimulants, there's a high risk of causing other medical problems, including heart problems, hypertension, and others. Here's epidemiology of use. You can see it's kind of an increasing trend in the West and the western part of the United States. There's the top blue line. It's been around for, you know, it's been around and being used a lot. And the rest of the country is catching up now. When you think about medication-assisted treatment for opioid use disorders, the way to, and this can be kind of for general approach to treating substance use disorders. These, right? So you have here using the empty opioid receptor as kind of an example, right? What do opioids do? They're agonists, so they go into the opioid receptor and trigger a response. Okay, so methadone, this first example, works as a medication-assisted treatment by mimicking, right, what the drugs of abuse do to bring down the effect of withdrawal and kind of the craving, this constant craving that ensues after chronic substance use. The next step, buprenorphine, is different in that it's a partial agonist. What it does is it triggers the opioid receptor to do its thing, but there's a cap, right? So you can put in lots and lots of buprenorphine, but at some point there's kind of a cap on its effect. So in theory, people really can't overdose on buprenorphine because it just naturally has a cap on its impact. And then naltrexone is an antagonist, which blocks the receptor from allowing opioids in. So, for example, somebody takes naltrexone and then use opioids, the naltrexone will actually block the impact of the opioid hitting the receptor. So the reason this graphic is important is because it essentially describes 3 different ways that medications can help with substance use disorders. And what's interesting is medication-assisted treatment is actually available for several substance use disorders. One is opioid use disorders, right? We just went through 3 different approaches: methadone, buprenorphine, and naltrexone. For kratom, it's an opioid-like response, and so if you can actually treat it using buprenorphine or naltrexone. Alcohol use disorder, actually you can use naltrexone, gabapentin, disulfiram, and acamprosate. So 4 different medications that can be used. For cannabis use disorder, gabapentin and N-acetylcysteine, or NAC, can be used. And last year, in the journal, the Journal of the American Medical Association, there was an article showing that you can use a combination of Wellbutrin or bupropion and IM naltrexone for meth use disorder. And there's also some research being done in providing long-acting antipsychotic medications through injection as a way to kind of reduce meth use. And for most substance use disorders, motivational interviewing and 12-step facilitation represents sort of the best practice or a standard of care. And so those are kind of the psychotherapeutic supports and approaches to work with folks who have substance use disorder. Why don't I stop there and open it up to questions and comments?
So I just put a question in chat. I was just wondering if there was any lower age limits where medication-assisted treatment wasn't recommended.
Sure. So I would say, so for severe substance use disorder, for in particular severe opioid use disorder, going down to age 16 is okay. Below that, it's going to be kind of clinical judgment, but I would say 16 and up, and you have severe opioid use disorder, using MAT is indicated. And again, as a kind of reminder and context, harm reduction is kind of the approach that most people who do this work and are trained to do this work engage in. And so what does that mean? If you have someone who's using, let's say there's a 15-year-old, for example, let's talk about a 15-year-old shows up and maybe for some reason is using kind of prescription opioids and possibly heroin, doing some IV heroin. And we know that using those drugs associated with a lot of potential complications, and potential infectious disease, overdose risk, and so forth. And if you got somebody that age who's struggling with severe use, that's where you kind of want to have this risk-benefit calculation. Do you let this person continue using, given all the risks associated with it, or do you engage in medication-assisted treatment, again, which have its own set of risks, but now you're participating more in that person's day-to-day sort of life, right? And so which one of these is likely to produce less harm? And that's kind of how you want to make the calculus of what you do. Let's see. What else? Other questions or comments?
Dr. Arzubi, I just thought about some adolescents that I see in group homes who are currently on stimulants for ADHD. And do you feel like using that medication, utilizing it maybe at a higher dose to help control cravings or perhaps to help prevent relapse in addiction is appropriate or not? So
are you saying for like using stimulants to treat cravings for what? For meth? Okay, got it. So apparently there's been some work done. And it's the outcomes aren't that great. So using stimulants, and it's been tried, and it's a great idea and a great question. It's been tried, but the outcomes aren't as robust as they are for some of these other approaches. So a lot of times, and it's sort of related to your question, I've met lots of adolescents who have untreated or undertreated ADHD, and having untreated or undertreated ADHD is a big risk factor in actually developing substance use disorders. And sometimes there's still the feeling that giving kids stimulants will make it more likely that develop substance use disorders, and where the opposite is actually true. I'll give you, because what you're, again, ADHD is trouble with regulating attention, and it starts playing into the ability to regulate emotion, right? So, but self-regulation, right? And so if somebody struggles with self-regulation, they're going to reach for tools that allow them to feel like they're more regulated. So we can either give them healthy ways of doing that, or relatively lower risk ways of doing that, or they're going to reach for things that are kind of maladaptive to kind of start feeling like they're regulating. And that's where they cross over into using substances. And that's why also trauma, the relation between trauma and substance use disorders is that desire to kind of want to regulate these difficult emotions and feelings. So anyway, that's and there's another interesting statistic. If let's say you find a group of 100 people who have at least one ACE and a substance use disorder, okay, you take that group, and with a magic wand, you make the ACE disappear in the entire group, you will actually make about 50% of substance use disorders disappear. So that means that the link between adverse childhood experiences and substance use disorder is very, very strong. And so that's something always to kind of keep in the back of your mind. And, I'll give you, there's a woman, it was an adult woman I was treating. She had certainly alcohol use disorder and used other substances too. And, was asking about Adderall. And I know a lot of us have kind of this gut feeling of, gosh, they have substance use disorders, so I'm not going to give Adderall. I would, again, just encourage us to think about the big picture and again, this is an N of one, so I'm telling you about one case, but, I was thinking, okay, definitely the woman definitely had ADHD. I mean, she was really very, kind of very distractible, not very organized. I mean, it was obvious in just the way she was presenting. And I asked a lot of questions about her history, but when I started, and I'll admit I was a little bit reluctant at first to kind of go with stimulant. I tried giving her Strattera for ADHD, didn't do as well. I gave her Adderall, and man, she looked so different and much better and more regulated. So again, I'm not saying you give anybody who tells you they have ADHD, you give them stimulants, but again, I would encourage us to really think about that risk-reward calculation, and if there's really ADHD, at what cost are you not giving someone a medication that might have a big benefit? There's a question here. Cannabis use or abuse with a generation of increased use. What's treatment before medication therapy? Do you usually encounter these patients once they have psychotic episodes? How does gabapentin help? Is there an emesis cannabis syndrome that reveals the addictive nature of use? So a lot of good questions here. So treatment before medication, right? In other words, prevention, right? That's obviously the identifying folks who you feel might be at highest risk. Again, we know, right? You'll see that slide I sent. That slide I sent that I presented on early risk factors. Those are kind of things to look out for and do some early education. So that's kind of the prevention piece, right? In terms of encountering patients once they have psychotic episodes, then it's too late. Well, it's pretty late in the game at that point. If they've developed psychotic episodes in the context of cannabis use, that's now you're kind of later in the game, and now you have to kind of you may end up having to treat the patient with an antipsychotic to kind of get rid of the psychotic symptoms, in addition to kind of working on motivational interviewing and perhaps medication like gabapentin or N-acetylcysteine. Gabapentin, interestingly, it actually the mechanism and how it relates to cannabis use is not understood very well, other than we know that gabapentin can reduce anxiety and some feelings of discomfort, which can help go after some of the feelings, the cravings, and N-acetylcysteine does something similar. And then the emesis cannabis syndrome, again, it appears in some people, like with very, very heavy use. So it's not necessarily a great indicator, because you don't always see it, or it's maybe not always reported. So certainly something to ask about. But again, big picture, gabapentin Gabapentin might help the person you're treating with kind of self-regulation of some of the anxiety symptoms, can help reduce some of the cravings, as can N-acetylcysteine. And because the emesis related to the sort of the heavy cannabis use doesn't always show up or doesn't always reveal itself, so that can be difficult to use as a marker. Cyclic emesis is mediated through substance P, so doesn't respond to antiemetics. Does respond to hot showers. Yep, capsaicin applied to abdomen. That's right. Yeah, hot showers in particular. Good point. Thanks for bringing that up, Sean. Other questions or case, clinical questions, other thoughts? I would say that the medication-assisted treatment of substance use disorders, it probably is very likely underdone. A lot of folks don't feel comfortable with, well, I'll give you an example. We do telemedicine all over Montana, telepsychiatry all over Montana, and I'd love to be able to have access to someone, a clinic or an organization that is able to do Vivitrol injections in every county. I'd love to have something everywhere. But primary care clinics will often feel uncomfortable doing that. Right? It's interesting, these same primary care clinics that will they give all the other injections, but when it comes to anything kind of like psych related, they get squirrely, which is unfortunate because we also know that long-acting injectables can be very useful to folks with severe mental illness. So we're actually working with, this is actually incredibly encouraging. We're actually working with Albertsons pharmacy, so the supermarket, on maybe making access to some of these injectables available in all the communities that they serve, because they're actually very open and willing to work with us on this. So I'm excited to make these sort of things more available, and would encourage you in each one of your states to see if you can identify a pharmacy chain or a supermarket chain that has pharmacies to get people more comfortable with giving access to these medications that can be very helpful. Contingency management with youth. I know it's studied most with meth, but they're used for contingency management in teens or other substances too. Yes, I know that. I think some studies have been done with cannabis, and contingency management, for those of you who don't know, basically means giving positive reinforcement or rewards for desired behaviors, right? Could be money, chips, tokens, anything of value or worth. And so basically what you're doing is you're rewarding for folks. You actually reward them with money for coming with a urinalysis that doesn't show any drugs or alcohol. What criteria do you use to determine whether a patient is a danger to themselves and break confidentiality to involve parents when they're discussing their use? I talk about it with the youth, and keep in mind, like I'm not sure what they are in the other states, but the youth in Montana, 16 and up, can consent to their own mental health treatment. So just being aware of that in Montana. I'm not quite sure what it is in the other states, but I try. As much as possible, if you have their trust and they're willing to talk to you about it, I mean, that's a precious thing, and I try to preserve that and not involve the parents unless you think it would be useful and helpful, right? So that you'd have parents who are supportive in the kind of recovery process, right? Because you don't know if you have a good sense of how the parents might respond, I mean, that's going to be important. And then obviously trying to work with the youth as much as possible and getting them comfortable to kind of reveal this to their parents, because obviously if you have buy-in, that's critical. When do I break confidentiality is, same way I would when I'm analyzing kind of the risk of suicide, right? Is I'm looking at imminent risk. So, for a youth, I don't know, let's say they're in a couple of the episodes of suicidal ideation or even kind of suicide attempts in the context of heavy alcohol use, and you're getting the sense from the youth that, I don't know, broke up with a girlfriend yesterday and is going to get drunk tonight and had a suicide attempt 2 weeks ago and the consequences of alcohol use, I'm going to break confidentiality. Right, but versus it's chronic, there'd been no past suicide attempts, then you kind of measure it differently. So I would be looking at what is the risk of imminent harm in the youth, hurting him or herself or hurting others, right? Let's say youth that says, going to party, I'm going to get wasted and I'm driving, I don't care what you say. Obviously, imminent risk, I break confidentiality. Other questions? Cool. Well, I appreciate everybody listening and tuning in. You'll get the slides after they've been scrubbed because I, again, handed them late. But hopefully that'll be helpful, and hopefully these presentations are helping you guys. So thanks for everyone.
Thank you.
Bye, guys.
Bye-bye.
Thank you.